Welcome, everyone. I'm glad to see such great attendance to the summer meeting of the CKD Clinic Network. For anyone that's signing on new to one of the network sessions, I'm Monica Bolia. I'm one of the nephrologists at St. Paul's in Vancouver. And I'm very supported by Selena Alu, who's on the call as well, and the whole CanSolve team in putting together these sessions. And I'd like to start by reflecting that I am taking my call on the traditional, ancestral, and unceded lands of the Musqueam, the Squamish, and the Tsleil-Waututh. And it's great to see so many of you, and I encourage you around the country to reflect on the lands that you're on. And today our session is one of transitions for the CKD clinic community. So we wanted to give a little bit of information about transitioning to in-center nocturnal hemodialysis and some insights into this therapy. And so it's my privilege today to introduce our speaker, Dr. Jeff Ma. Jeff's a nephrologist and clinical associate professor at the University of Calgary. He's the director of the in-center nocturnal hemodialysis program at Foothills in Calgary. And Jeff, thanks so much for signing on to a session in the summer to share some information about this treatment option and give us a little bit of information. Jeff,
sure.
Your slides are up and over to you. I just wanted to do a little housekeeping. The chat is open. So if there are questions, feel free to put them in the chat, and there is some room at the end. And Jeff, you let us know if you want us to wait to the end or hands up. Up to you.
Sounds good. Maybe if there are questions, we can address them at the end. And if there's any pressing ones, we can address them during the discussion too. But how about we talk about that at the end? And good morning, everyone. Thank you very much. I'm very happy to talk about the in-center nocturnal hemodialysis program. I'm one of the nephrologists based out of the University of Calgary. And this is a program that's nearing a decade since inception. So what I'm presenting today is what we've learned from where we are and what we've learned from the program. The program was started by one of my colleagues and mentors, Dr. Jennifer McCrae. And so she started the program and I've subsequently taken over for the last 4 or 5 years or so. So first off, in terms of the objectives of today's discussion, so I want to describe in our center, the enrollment and structure of in-center nocturnal hemodialysis and how this modality may benefit CKD patients and patients with ESRD or approaching ESRD, and also discuss some of the learnings of our program within Calgary. And our Reno program is part of a larger program with Alberta Kidney Care South. So just a couple of fun points about Calgary. So Calgary is a very sunny city for those that I've had an opportunity to visit. So there's 333 sunshine days per year. So it's Canada's sunniest city. It's also very cold as well. So if you come in the winter, it can be quite chilly. So I think the record is -45. That's been documented. Calgary is known for its downtown network of overpasses and tunnels, a lot driven by the weather as well. So the downtown is connected pretty extensively. The Caesar was invented in Calgary back in the 1960s, and ginger beef was also invented in Calgary in the 1970s. So why nocturnal or intensified hemodialysis? So we know that there are benefits that come from intensified hemodialysis. So the clearance of solutes is markedly enhanced with intensified dialysis. This includes urea, phosphate clearance, beta-2 microglobulin as well. There are cardiovascular benefits to intensified hemodialysis. So there's improved blood pressure control, perhaps less use of blood pressure medications, regression of left ventricular hypertrophy or LVH on echocardiogram. There's also improvement of vascular function, as well as ejection fraction that we can see for patients on intensified hemodialysis. Intensified dialysis allows patients to liberate their diet, both in terms of the fluid intake as well as the food consumption that they have. It improves libido. And for female patients, it can also improve fertility of those that are childbearing age, and also is indicated for those that are pregnant as well with ESRD on dialysis. And it also leads to improvement of quality of life from patients in terms of the reported experience with dialysis. Now, there are very few outpatient procedures. Sorry, I just wanted to, there we go, yeah. I missed a slide there. So there are some considerations actually with intensified dialysis, though, even though there are benefits that come from it. So vascular access considerations. So it is longer use of the vascular access. So you do need to ensure that vascular access can support intensified or lengthened dialysis. Residual kidney function is also a consideration as well. So potentially there may be some accelerated decline in residual kidney function for those on intensified dialysis, potentially. Bone mineral metabolism also needs to be paid attention to as well. So if there's inadequate dialysate calcium, this could lead to a negative calcium balance and promote increased parathyroid hormone activity. And if there's overzealous dialysate calcium, it could also lead to low bone turnover and promote vascular calcification. So it is something that does need to be monitored with intensified dialysis. Cost is also another consideration as well. So typically intensified dialysis or more frequent dialysis is associated with higher cost. And I will get into that a little bit more with our program as well and how we've navigated that component. Now, there are very few outpatient procedures that happen overnight in the hospital. So if you think about what all the hospital does and how it's opened, a lot of the evening activities really is structured around emergency care as well as those that are admitted to hospital. When we think about procedures that are actually done in a hospital overnight, we think of MRIs perhaps. This is more likely a reflection of system crunches. So in Alberta, MRIs are often done close to midnight as well because of the access. EEGs in terms of patients that are sleeping at night in hospital and having monitoring for any type of seizure activity, sleep studies for those that have suspected or confirmed sleep apnea or sleep disorder breathing. However, these treatments are typically not reoccurring. So what makes in-center nocturnal dialysis special or unique is that it is a procedure that happens on an ongoing basis. And when you think about it, there are very few procedures where patients are coming to hospital multiple times in a week for ongoing treatments. So when we talk about in-center dialysis, how do we pair a procedure that is typically done during the day in an outpatient setting in an overnight capacity? And so some people may say, well, isn't this really the same as home hemodialysis? Patients are getting longer dialysis, they're getting it done anyways. It's the same dialysis dose or likely very similar. And what I like to show is that there actually are some unique considerations for programs, patients, and physicians when you are starting or are implementing a in-center nocturnal dialysis program or maintaining that program over time. And when we look at the literature, there really is a paucity of literature as to how to start or maintain an effective in-center nocturnal hemodialysis unit. And actually, when you dive into literature, there's actually very limited evidence for outpatient facility-based nocturnal procedures in general in terms of how to best optimize that. So what we've done in the Calgary in-center nocturnal hemodialysis program, much of it really has been iterative over time since its inception. So a lot of it was observation, interpretation of what we see, different interventions we've promoted over time, and really continuing that cycle again and again to ensure that we're meeting the needs of our patients. So as I mentioned, the Calgary in-center nocturnal program started in about a decade ago. We'll be hitting the decade mark this October. Currently, there are 34 beds at Foothills Medical Centre. This is the hospital center, one of the large hospital centers in Calgary. There are 3 beds that are isolation, and the rest of the beds are cohorted. So really, when these patients come in for their nocturnal sessions, they are actually joining a cohort of 16 other roommates really while they sleep at night. We have two streams. There's the Monday, Wednesday, Friday, as well as a Tuesday, Thursday, Saturday cohort. And we have a graduated time on and time on for starting dialysis, as well as a graduated time off. And I'll get into details why that is the case, but patients start coming on at 8 p.m. and with the last start coming on at 11 p.m. And the time off, they start coming off around 5 in the morning, and all patients are off by 7 in anticipation for the morning shift of dialysis coming in. So when this program first started, there was some media buzz in Calgary as well. So this is one of our former in-center hemodialysis patients when she was in the program. So I'm going to be using the Institute for Health Care Improvement, or the IHI framework for quality, to discuss how we've mapped out the in-center nocturnal program and how we've iteratively addressed certain things that have come up over the years in the program. So first, I'd like to start with safety. Now, building safety in the in-center nocturnal program was very paramount when we first started, and oh, sorry, there we go. Yeah, I just want to make sure I got the right slide there. So in terms of building the safety, the process map was very helpful in terms of providing insight. What we did was we looked at what a conventional dialysis nurse, in terms of the procedure of starting a patient on dialysis and the monitoring required during a dialysis session, taking them off, what that included. We also looked at, from the conventional dialysis patient, what their session looked like and what their experience looked like. And we also looked at, from a home hemodialysis nocturnal session for patients that were dialyzing at home, what they did as well in terms of mapping this out. The reason why it was very important to map this out was because a lot of the nurses that worked with the in-center nocturnal dialysis program, they were in-center dialysis nurses, so they were trained through an in-center model, frequent monitoring. And so in terms of understanding perhaps what the nocturnal session looked like, it was really important for us to map that out, so we knew that what patients did at home, what we did in center, were areas that we can optimize to help with fostering that nocturnal experience for patients. And through this process, it really did foster ownership and engagement, both from the nursing and allied health, as well as from the patient standpoint as well, in terms of how do we develop a program where many of these patients who were coming into in-center nocturnal, they weren't able to dialyze at home. That wasn't an option for them, whether it was because of water supply or because they were renters and couldn't change the structure of their home environment, or socially, perhaps it wasn't the appropriate option for them. So a lot of this has helped with the ownership and engagement of our stakeholders. Now, in terms of building safety into in-center nocturnal, so our nursing ratio is less at night, and this has to do with some of the funding support that comes with dialysis, and also the part of the intensified dialysis being a more costly modality as well. So we have 4 nurses to 17 patients at night, and so it's about a 1-to-4 nursing ratio, and actually at times it stretches to 1-to-6, because when you account for overnight breaks for these nurses, at times there really is only 2 or 3 nurses on the floor. There is no or NA support, or nursing attendant support, is not present in the in-center nocturnal program. So in Calgary, during the day, the nursing ratio is typically 1 nurse to 2 to 3 in-center dialysis patients, and there is typically 1 NA to 6 dialysis patients during the day, but certainly at night there is less support for this. Physician monitoring, so physicians, we would round to every 2 weeks. We would come in typically between 9 and 11 p.m. and round, but we wouldn't necessarily be staying in-house overnight. So in terms of building safety into in-center nocturnal, that's quite important in terms of the monitoring protocols in place to ensure that things run smoothly, and to ensure that we have the right level of monitoring for patients. Patient independence is a large factor in terms of how we've built the program. So there's a lot of fostering of patient independence in terms of when they come in, how they set up, and as well as how they take their medications during the evening, and as well as monitoring their blood sugars, giving themselves insulin. Nursing comfort was a large area which the process mapping helped with. This was comfort in terms of, for these nurses, as I mentioned, a lot of them come from an in-center experience, so having patients self-needle, having patients hook up the CVC themselves. This is certainly more of a theme that we would see in home hemodialysis, but not necessarily a theme that we see in-center hemodialysis. And then the monitoring of patients as well in terms of developing the comforts. So When patients first start, we monitor them quite frequently in the in-center program in terms of blood pressure monitoring. But as you can imagine, if we watch the blood pressure every 15 or 30 minutes, they're not going to sleep. And that is actually one of the largest barriers to an in-center nocturnal program, is how do you foster sleep culture and how do you allow patients to actually get rest when they come into the overnight dialysis program. So we have a protocol in place whereby we look at the monitoring quite intensely for the first week. And if it's stable, then we start de-intensifying their blood pressure. And typically by week 3 or week 4, we're measuring their blood pressure two to 3 times per week. Many stable patients really just get a pre-blood pressure, pre-dialysis blood pressure, and a post-dialysis blood pressure. This is when we first started this program, it was very foreign to nursing. With this degree of blood pressure monitoring. So making sure that everyone was comfortable with this and that patients knew how to contact or ask for help if they weren't feeling well. This was quite important to establish. Sometimes we do a mid blood pressure run as well, a check as well. And this is particularly for patients where we're starting to take off more fluid or patients that have significant intradialytic hypotension. We typically do also a one-time blood pressure check mid-run. Patient-driven weight discussion is also a very prominent theme as well. Patients come in, they weigh themselves, they discuss with the nurses how much they want to take off. Many of these patients, part of the reason why they are in-center nocturnal is for that liberation of their diet. So we talk about the type of volumes that they would be taking off over their 6 to 8 hour nocturnal session. And then, as I mentioned, self-administration of medications as well. So many of these patients, they will be bringing in their medications from home, taking their evening medications, monitoring their blood sugars as well, and taking their insulin. Now, in terms of human factors and the environment, so sleep and safety is a very prominent theme as well. So in terms of as I mentioned, you have 17 roommates really in a room, and how do you situate the patients to ensure that some patients that perhaps are higher acuity are closer to the nursing station, patients that are lower acuity can be farther away from the nursing station. The lights turn off in the dialysis unit at 11 o'clock. This is to help with promoting sleep as well. So the unit is completely dark. Patients do have their light by their bedside as well. And when we first so when we started this program, oftentimes we kept it with the curtains open, but over time we realized, patients want their privacy at night. So all the curtains are closed. And when the curtains are closed, how do you keep that monitoring? That culture has changed certainly now with COVID. Typically with COVID, we do close the curtains as well. But when the program first started, it was having an understanding of, well, the curtains are going to be closed for most of these patients. That's usually what they would like. How do we foster that monitoring, and how do we foster that comfort level with that as well? The use of call bells and alarms. So they're very important. However, they can also be very loud. And how do we factor that in terms of fostering that sleep environment? Washroom visits as well, and managing fall risk. So many of these patients, we do talk about using commodes at the bedside. Some patients still wish to use the washroom, and in that scenario, we do talk about, well, how do we foster getting them to the washroom without necessarily opening all the lights on the unit to allow for the other members to continue to sleep. In terms of equity, when we first started this process, so many dialysis patients come to dialysis through healthcare or publicly funded transit services. So in Calgary, we have Calgary Transit Access that transports patients to and from their appointments, including dialysis as well. And when we first started this program, Calgary Access was quite, I think, surprised by the number of requests we had for patients to come to the hospital in the evening. And at the beginning, they weren't actually able to accommodate our requests. So certainly transport really is part of the process map, is how do you set that relationship up to allow for access to patients to come to an overnight dialysis session. And so there was quite a bit of work that was done to help foster that, and also to ensure that we had funding for that as well. Funding for also overnight parking for patients that are driving to their dialysis sessions. And then also a discussion around with patients and family members in terms of evening commitments regarding the visitations and start times as well. This is also to ensure that the culture of the in-center program, that patients understand there's a certain graduated start time that where patients can come in. However, we also recognize that with different commitments, maybe on a Friday night, they'd like to go out for dinner, they want to come in a little later. And so we foster that and we promote that as well. But we also talk about what the appropriate times are for that as well. So during the daytime sessions, if a patient came in 90 minutes late, we in Calgary, we'd start them. We wouldn't necessarily defer their session if they've come in. But for patients that are coming in at 2 in the morning after a nice dinner and maybe a party outside, how do you foster that culture? Because the unit is dark. Do we start them on dialysis? Do we or do we ask them to maybe come back? And so fostering that culture is very important for that sleep and also for safety as well, because of the lighting, and also at night the nursing ratio is much less. In terms of efficiency, so the reason why we have graduated start times is important for one, washroom use for patients as they prepare for sleeping overnight. And also because of the lower nursing ratio, it also allows for a longer time, a runway for nurses to actually put patients on for dialysis. This graduated start time also allows patients to set up their bed environment before the lights go out. So many of our patients will bring their own bedding, they will bring their pillows, and they'll set up a environment really that allows them to sleep and to enjoy their time at dialysis. And then we have the graduated off time as well for similar reasons, for washroom use, the nursing to allow for appropriate timing for each patient to come off as well, and then for patients to pack up their belongings too. Engagement of family to help prepare patients is very important. And so this is similar to the approaches that we see in home hemodialysis in terms of how do we set patients up for success in dialysis. And there's significant social worker engagement as well. So every patient who starts in the in-center program, nocturnal program, will have a social work review to talk about what their expectations are of the program, to also talk about what that first month might look like, because there is quite a bit of adjustment that occurs during that time. And also with that, to identify if there's any barriers that might come up, whether it's with transportation or with perhaps home commitments that patients have to attend to in the evening as well. Now, in terms of efficiency, I also want to talk about the system as well and the pressures of the system. So like a lot of, I suspect, centers in Canada, there's been increasing demand for dialysis services over the years. And so this applies to Alberta Kidney Care South as well. So in the Southern Alberta, we have close to about 1,300 to 1,400 dialysis patients. And when we look at the type of dialysis patients in terms of their needs, most of that growth really has been facility-based hemodialysis. Whereas when we look at our data in regards to our home dialysis programs with peritoneal dialysis and home hemodialysis, those numbers have stayed relatively similar over the years. And so the dialysis units in Calgary now are open. So the one at Foothills, the center where the in-center nocturnal program is housed, is open 24 hours a day with the overnight program. It's also open 7 days a week. Many of our dialysis centers are open 7 days a week now to accommodate the demands that are required for dialysis. So when we talk about our in-center cohort, in nocturnal cohort, we have 34 patients on extended hemodialysis. This is likely similar to 65 or more conventional dialysis patients in terms of building capacity into the program. In terms of patient-centered care, so over time, there's individual care plans that are set up for each patient. This includes pillows, the bedding. Nurses have a pretty good understanding of what each patient will need over time to help with their overnight session. Sleeping aids that are utilized as well in the in-center program. Some patients do take sleep aids pharmacologically as well to help with that. We have masks that we provide patients as eye masks, that we provide patients. So masking was interesting. So during COVID, during the earlier stages of COVID, it was actually quite difficult all of our in-center patients were all asked and promoted to wear masks. And so that actually was quite a difficult task in the overnight program. And so we did have to talk to IPNC in regards to how do we best address this scenario, because for a patient to mask and sleep overnight, it was becoming very difficult. So that actually led to universal closing of curtains for all the patients, and most patients already had the curtains closed, but we had to do that during the earlier stages of COVID as well. The care plans are also set up for setting up, as well as how patients, we know that which patients are going to weigh themselves, which patients are going to calculate their weight loss and what that might look like, which patients do want to needle themselves, which patients would like nurses to help with needling, or at least monitoring for the needling process. And then washroom assistance overnight, we also have that set up as well, understanding which patients would like to use the washroom, which patients are open to using the commode. And these care plans are revisited periodically to foster patient engagement. Now, the patient engagement, it has changed over time with the program. So I would say that when the program first started, the program was probably more on the left hand of the spectrum, where it was more of the certain issues that had come up or patient complaints that had come up, and how we listened to that and how we tried to seek out the information with that. But over time, now that we have this experience with our cohort and experience of how patients coming into the program in terms of how we onboard them, really now it's experience-based co-design. So when patients leave the in-center program, our social worker will speak to them as well in regards to what was it that worked for them, what was it that did not work for them, and we continue to iteratively change our program for that. Many of our patients leave the in-center program typically because they get transplanted. That's the main reason at this point why patients leave the in-center nocturnal dialysis program. We have a nocturnal hemodialysis agreement that the social worker will discuss with the patient as well. And this is to help with fostering the culture of sleep within the dialysis unit, and also recognizing that the monitoring is less in the overnight session. So we ask that patients that they have one visitor, that visiting hours end at 10 o'clock, and that in terms of the use of electronic devices such as cell phones and iPads, that they use headphones to avoid sound and disruption. We also ask that they don't have telephone or cell phone conversations after 10:30 as well, unless there's an emergency. And we also talk about other components as well in terms of the understanding that that patients should not be inebriated when they come to nocturnal dialysis, and that when they do come, that we have an understanding of what that sleep culture might look like. In terms of the timeliness of the therapy, so timeliness really refers to the right care to the right patient at the right time. So there are, from a medical standpoint, certain indications where patients do come into in-center nocturnal dialysis. So one is intensification of dialysis with the goal towards transplant with those with severe LV dysfunction. So for those that are perhaps waiting for living donor kidney transplant, and we know that the EF is somewhat more marginal, we do bring these patients into the overnight program to help optimize their cardiac function before transplant to help improve the outcomes. For those that are ineligible for kidney transplant, intensified hemodialysis may be the most optimal form of renal replacement therapy for these patients. That is another consideration we have as well. Patients who develop calciphylaxis and need to come to hemodialysis multiple times, more than 3 times a week, we would bring into the program. Patients with recurrent volume overload or intradialytic hypotension, or patients with very high intradialytic weight gain, we bring these patients in as well. Patients with ongoing hyperkalemia that is not managed with conventional dialysis, we would bring in as well. Many of these patients are also on potassium binders in addition to their regular 3 times a week run, and that's another scenario where we'd bring these patients in for intensified dialysis. Severe mineral bone disease or hyperphosphatemia, and pregnancy as well. Enhancing independence is also a very strong theme as well. So some of our patients would like to go to school and are going to school, and so having dialysis overnight allows for that. Work commitments as well as family and lifestyle commitments. When we talk about effectiveness, so this is a paper that was published by Braden Manns, one of the nephrologists in Calgary, and he looked at the top research questions in the area of kidney failure and dialysis, and the themes that would come up for patients over time as they navigate their end-stage renal disease journey. And what we see is that in-center nocturnal dialysis does address multiple themes that seem to come out with patients, as well as the research questions that are born out of the discussions with patients as well and healthcare providers. But in-center nocturnal dialysis is to maximize patient participation, to facilitate self-management. It is a discussion of perhaps one modality is better for some patients than another modality, and really tailoring that modality for the right patient. Preventing itch is also a common theme that we see as well for patients, particularly patients that are quite hyperphosphatemic or perhaps underdialyzed. The psychological and social impact of kidney failure on patients, and how this could be reduced to allow patients to continue to live with their independence. Promoting heart health with improved blood pressure control and ejection fraction improvement. Dietary restrictions that come up for patients as well. When patients are on intensified dialysis, this allows them to liberate their diet. And then also, how do we best manage symptoms in people that are nearing dialysis, or patients that have poor energy, nausea, cramping, restless leg? Particularly with the cramping, sometimes bringing them into more of an intensified dialysis, but perhaps a slower rate of fluid removal may help with some of these symptoms that these patients have. In terms of some of the data published with our program, so we did do a quality of life measure with our cohort. And what we found with these patients is that patients over time had less use of hypertensive medications and phosphate binders. They also had lower calcium and phosphate levels as well. There was improvement of the mental health scores at the 12-month mark following enrollment. And patients really with the lowest baseline quality of life that was documented, they tended to be the ones that improved the most with the in-center nocturnal program. So since the program has started, there's a couple of scenarios that really patients we wouldn't have conventionally thought of bringing into in-center nocturnal dialysis we've brought in, and we've seen the improvements that this modality has provided for these patients. So those with intradialytic hypotension with very low blood pressures at baseline, blood pressures of 80s to 100, being able to dialyze them at night and check their blood pressure 2 to 3 times. Patients, we've supported in the program a patient who has been pregnant as well. So her child is now 7 years old, and this was allowing for intensified dialysis in a less monitored environment as well. Optimizing ejection fraction to allow for kidney transplant clearance, particularly for those that are awaiting living donor transplant, and also those for deceased donor transplant as well. Enhanced independence, allowing patients to go to work and as well as go to school. Calciphylaxis, as well as this is one that I think when we first started the program, we had not anticipated, but it actually has, for some patients, improved their adherence for those that could not adhere to conventional hemodialysis. So a number of our younger patients, perhaps, that weren't always coming to dialysis, we found that bringing them into a nighttime program that wasn't as loud, there wasn't as much hustle and bustle. It seemed to be a much more calmer environment. It also perhaps worked with their schedule a little bit better as well, that seemed to foster increased adherence for patients that were not coming to their conventional dialysis sessions. So in terms of determining selection and eligibility criteria, so there are patient indications, whether it's patient independence lifestyle, medical necessity that I talked about, or element of both. And then also program considerations as well in terms of what the nursing monitoring is required and what the physician monitoring would be required for the patients, the space that we have, as well as the time constraints with this on and off times, as well as the 2 dates that we have. But for these patients, we suggest everyone have everyone has a 1-month minimal trial to really troubleshoot matters and to adjust to the sleep environment in hospital. Many patients we know will not be sleeping for the first few weeks in the in-center nocturnal program, and we really do work with them to see what we can do to help improve their sleep environment. The other thing that comes up too is that we don't know before really is whether these patients snore or not. We ask that, but many patients don't know if they snore. And so that is also another area too, that if they come in and they snore, then we have, and it may be difficult for the neighbors as well. So we start troubleshooting and trying to look at other locations or whether they have to go to the isolation room or whatnot. Much of what we do is overnight, but we do actually have multidisciplinary rounds with in-center nocturnal dialysis. So we have a monthly review during the daytime hours with the nurse clinician, with the physicians involved, social worker, dietitian, pharmacy, as well as our dialysis unit manager as well. And we talk about the program matters, the safety review, and quality assurance. We also review the patient statuses as well. And this is where we review patients that are coming into the program, as well as patients that are exiting the program, whether it's due to a sleep issue, a medical issue, or as I mentioned, many of these patients have exited because of being transplanted. Waitlist management as well. So this is a resource whereby it is resource intensive, and so for patients that are awaiting a spot in in-center nocturnal, how do we manage that wait list? And with that, we determine what medical criteria perhaps exist and also what the social indications are. During these reviews, we also talk about the transplant workup in terms of where these patients are at in their workup, or if they're active and waiting. Home modality review. So this still continues to be, for many of these patients, once they become more comfortable with this type of dialysis, we also talk about, well, could they also do this at home? And what are the barriers that exist right now that are not allowing them to do this dialysis at home? And then we also talk about access review as well. As I mentioned, because of the longer sessions of dialysis, there is more reliance on stable access, and so we review that at that time as well. And so this is a limited resource, and what we are trying to do is maximize utility that comes from this with our in-center cohort. And if you look at it, really, so my other hat is in kidney transplant, and that's half my practice. And so really, over time, we've really started to discuss how do we allocate a scarce resource to help with maximizing the benefit for patients. And it looks very similar actually to a transplant multidisciplinary discussion as well. So I'm coming to the end of my talk. So I hope I've been able to describe the enrollment and structure of our in-center nocturnal dialysis program. How can in-center nocturnal dialysis benefit your patient and benefit the healthcare system as well? And also some of the learnings of the program to foster quality care. Thank you very much, everyone.
Thanks so much, Jeff. Any questions for Jeff? You can actually just unmute and speak if you have any questions.
It's Sandy Vanderzee here. Thank you very much. This has been really interesting and informative. I really appreciate that. In Alberta Kidney Care North, we do have 2 nocturnal programs at 2 acute sites. One of our challenges is due to our capacity. We're running an evening shift that goes to about 11 o'clock. And so to get the patients on dialysis early enough that they get a decent sleep is one of the challenges for us. So really commend you. I know you've got some stations dedicated in the evening that you can get patients on. And I think if we could get our capacity challenges in control, that we would hope to do that as well. And just wanted to comment, you made you touched on some really interesting points that I've thought about over time. And you mentioned the education for the nurses. And I was a hemodialysis nurse many years ago in Manitoba. And that culture of control for dialysis nurses, I think, is pretty strong. And so to loosen up and only do a blood pressure maybe once or twice a night and not being able to see the patient, are they unconscious or are they sleeping? So I can see that it's really important to educate and to have that mindset change. And like you said, it is it's really about enhanced patient care. So just wanted to really commend you and thank you for the presentation today. It's been excellent.
Oh, thank you very much for that. So I would say, so in our program, we do have dedicated beds. So the in-center nocturnal program is also based on an acute care site, and what we've done here to allow for it in terms of the graduated time on and time off really is the side that we have are inpatient runs that so our dialysis unit is split into an outpatient side and an inpatient side, and it's all in the same unit, but it's just cohorted differently. But the inpatient side, we really try to free up those beds, some of those beds before around 8 o'clock, so that allows for that graduated time on as well. We have been talking about expanding our program to another site, whether it's another acute care site or perhaps an outpatient dialysis site. And so part of that discussion that we've been engaged in is how do we do the disinfection, and how do we look into that to help with minimizing the time required to allow for the unit really to operate for 24 hours a day. So I do recognize capacity so conventionally, many patients were Monday, Wednesday, Friday, Tuesday, Thursday, Saturday, but that's becoming less and less of the case now, where we have patients who are on an incremental dialysis, where they're on twice a week, perhaps when they start, and then patients that are on typically the unconventional schedule is really more the conventional now, where patients aren't necessarily on these set days anymore. So I definitely appreciate and recognize there's a lot of system pressures with our growing ESRD population.
Thank you.
There's a question in the chat about patients feeling cold in the day, so it might be a bit colder at night. So how do you deal with that? Patients being cold?
Yeah. So we do. So in terms of the temperature, so we do. We typically either it's a bit of troubleshooting. So we either do body temperature minus 0.5, or we try to set them at 35.5 and see, and then we really see how that works with them. If their blood pressures are stable over time, we do try to raise the temperature a little bit to see if that would help with their sleep quality. Many patients are bringing multiple blankets in, truthfully, so at night as well. The BTM, which we also do a lot for a daytime conventional patients, we find that we don't do that as much with the overnight patients. We find they get too cold with that. That's the one I find that they discuss about a little bit more in terms of feeling cold.
Jeff, one of our in-center nocturnal is very, very similar. One of the lovely learnings we had over COVID was on the first day of the COVID pandemic with CPAP. So
yes.
People using their CPAP machine. What's your experience been at CPAP through the pandemic, and have you changed your protocols?
Yeah, so certainly the protocols have changed over time. So when the pandemic, at the earlier stages of the pandemic, so many patients, when they come in, they may not even have a diagnosis of sleep apnea, but we see that they're snoring, we see that there's apneic episodes, and that they get diagnosed actually after they're in the program. But for patients who are on CPAP, at the beginning of the pandemic, we really tried to put these patients in our isolation rooms, and we tried to work with it so that we actually rescheduled their runs so that they would have an isolation room. And so we had 6 in between for the 7 days. So we were able to kind of work around it. But the challenge really is when these patients become symptomatic, what type of isolation protocols should you have? And so, in Alberta, it was different depending on whether they were an inpatient or an outpatient, interestingly enough, but in terms of that contact and droplet precaution. But we wanted to be cautious because it was an extended amount of time. Like, these patients really are here for 8 hours. So, and so that is quite a bit of contact time. So we erred on the side of being more cautious, and we worked with IPNC around that. And so we actually kept these patients on contact and droplet if they were symptomatic as well. And in the isolation room, and during that time we actually held off patients who were if there were new requests to come in, we actually held off if they were on CPAP. We've since loosened up in that, and so now many of these patients coming in, it really is a symptom inquiry in terms of whether they're symptomatic or not, but they are now using CPAP on the floor as well, whereas before we would have them in the isolation room.
Yeah, thanks. Nancy.
Thank you. I've got a question for you as well, and that's, I've been a home dialysis patient. My claim to fame is I was number 2 in Alberta all those years ago. So my question is, had you considered actually including some home training during the nocturnal program? Because many people can't go home because they can't train during the day. They've got to work, they're going to school, they have family, and or something I'm really hoping our Alberta will change is doing more self-assisted. So people come in and set up and put themselves on and go, so that we're really promoting that independence. And because the comment about control was just made me smile, because that's just to give you an example, I had gone to a nocturnal run in Edmonton at the U of A and had a nurse tear a strip off me. I've been home forever. And if you touch that machine and we're liable, and she went up one side of me, down the other, and it was, hello, excuse me. And I literally said to her, well, look at it this way. If you don't get here soon enough, I'll be touching that machine. So, but the point here is building another opportunity to get people home and or to get them more independent. So even though they're still nocturnal, that they're setting themselves up rather than being done to, as it were. Does that make sense?
Yes, and thank you, Nancy. So it's a great point you bring up. So I would say so first off, with in terms of the fostering the independence part, that's actually been a very strong theme in terms of how discussions of how we're hoping to expand the program. So so our current in-center program is at an acute care site, whereas in terms of the discussions around expansion, we've actually talked about putting it near the home hemodialysis clinic, and maybe having patients run close to there to help with fostering that training those training opportunities that would come up, and also to help with understanding, there probably is a spectrum where there are some patients that are very independent and that they can do it at home, but because of perhaps their living situation or social circumstances, they can't. And then patients that really do need some more medical monitoring, and from a medical standpoint may not be able to continue to do this at home as well. So we are recognizing there's certainly a spectrum for that, and so that has come up in terms of our discussions of how, when we expand the program, what are the needs that we're trying to address with that. I would say the other thing too, with our program and what I've seen with the nurses over time is that for them, when the program first started, there was a lot of monitoring. There was a lot of physician monitoring as well, because I think we were all a little bit more apprehensive. But over time, as we got more comfortable and we got to know the patients and their individual needs as well, that really allowed for really a discussion around that. So the nurse, many of our nurses in the in-center program, because we also have to, for us, in terms of from a nursing side of things, like, what would in terms of the recruitment and retention, for some of our nurses, and many of these nurses were in the daytime program, and so why would they want to all of a sudden do night shifts, and they're not even working on the inpatient ward or working in an emergency department? And I think the reason why is because these nurses see the benefit that comes from these patients over time. They see that these patients enjoy their dialysis. They tend to stay in our program. They see that we're trying to use a lot of efforts in terms of personalizing their care as well. And so many of our nurses in the nocturnal program, they actually have been there for quite some time. And I think part of that has been to foster that comfort level over time with patients. They know the patients very well, and also understanding that there can be a little bit more of a discussion with patients in terms of perhaps a bit more of a dogmatic approach that might come with other dialysis experiences. So. Oh, I think you might be on mute, Monica. Yeah.
Sorry about that.
Yeah.
Joe, I was just wondering if your nocturnal nurses rotate into the daytime shifts as well, just to get both experiences, or if they primarily stay in nocturnal?
Yeah, so they do rotate into the daytime, but primarily I would say that they're in the nocturnal. So, so they do. We have them coming in during the day as well. So.
Jeff, how does your CKD clinics and your RRT modality education, is there any, do they include this, or how would you describe or frame it for CKD nurses that might be teaching someone about their options?
Yeah, so it is discussed during the modality education for CKD. part of the discussions, so we also have a dialysis transition unit in AKC South as well. So oftentimes the discussion really is around if the chosen modality is going to be hemodialysis, or if they're leaning more towards that, then we start talking about the dialysis transition unit and what that might look like for hemodialysis. And that's also discussed there as well. But there's actually also a strong discussion around can we, and for us, because of our dialysis transition unit being located in home hemodialysis, there's a strong discussion of home dialysis and independence. We also talk about peritoneal dialysis there, and we also then talk about in-center nocturnal dialysis. Each program, I think over time, there will be, we've seen a shift in the patient profiles that come into the in-center nocturnal program. So I would say that when we first started the program, a lot of the patients coming in, the reasonings were because of patient independence. That was really the reasoning. They wanted to come in. They had either commitments during the day, or it was better for their lifestyle. And over time, what I've seen is in our program that, and I think partly because it is based on an acute care site, is there's been more medical indications to come in to in-center nocturnal. And it really depends on the comfort level as well. Because the nocturnal program, there can be various themes that come up. And I think we have a mixture of patients, but truthfully, I do see that there's been more and more medical indications to come in. So patients that have very significant weight gains, that we can't keep up with their fluid control, patients that have higher BMI as well, and we know that their dose of dialysis probably, they would benefit from more intensified dialysis. Those are probably the ones we're seeing more and more come into the program.
I do have one other question for you. You mentioned that you did an assessment on quality of life. Can you tell me a little bit about how you did that?
Yeah, so that was done with one of our former trainees. And so as part of his master's project, he did a survey for patients. And they talked about the in-center, he surveyed our in-center nocturnal cohort and looked at some of the themes that would come up. And there was a score that he utilized to help with identifying what their baseline perceived quality of life is. And then also would check in with them at various time points to see if there's been changes to that over time. I would have to say from that discussion, really, when we onboard patients, we do talk about, like with any transition, it does take a little bit of time to work out and troubleshoot certain areas. And so what we've noticed with that, and that was in the earlier days of our in-center nocturnal program, was that sleep was really a big one in terms of how do we best foster sleep. And that was really the main reason why patients ended up exiting the program, was because they couldn't sleep. And so a lot of efforts were made to help with improving that. But we know that probably for that first month, that patient, they may not be getting the best sleep. And so a lot of it is reinforcement and having them discussing with the patient, I know it's maybe not great now, but just stick it out for a little longer if you can. And I hope that you'll feel some of the benefits that might come from this. And I hope that you might see that, we might be able to stop some of these medications, maybe not as much polypharmacy. Maybe we can stop some of your phosphate binders. You can eat some of the things you enjoy more again. But at the beginning, we know that it does take a little bit of time for us to troubleshoot it. So.
Right. So I was thinking about qualitative as well, is that very often I understand my choice of words, the fallback to surveys. And I noticed that you have a number of conversations with your patients as well, which I think is really important. And I was fascinated to see the transition to co-design for a care plan, because, for instance, but very often when people go home, the first word people use is, "Oh, you like to be in control," which suggests that I'm a control freak. The truth is, I like the flexibility of being at home. And I'm wondering if that's something you've considered with your nocturnal program where they could swap. So for instance, I really want to go to Symphony on Saturday night. It's my usual dialysis night. And technically it fits, but it's really tight. It just sort of ruins my evening. Could I swap with someone on Friday? Is there a patient-led setup for that? Because it's something that we really don't support or encourage at all.
Yeah.
It's sort of like, these are your days, stick to it, tough it out. But when it comes to quality of life, it's, wait a minute, I'm a grown-up. If I want to dialyze on a different day for whatever the reason is, and someone will swap with me, why can't I do that? So I'm thinking that nocturnal might be easier because it's a smaller cohort, etc. But anyway, just some thoughts to send your way.
Yeah. So we know there are certain life commitments, and for whatever the reason for patients, so the unit itself, and our nurse clinician, they're very good at actually trying to accommodate that. So what we will do if there is a event, let's say Friday night or Saturday night, and you know they want to stay out late, and we also try to be mindful that, you know, if you're staying out late, you know, what time were you planning to come? Because if it's, you know, if it's very late, it's also difficult for the other patients there as well. So we actually start switching their schedules if there's other spots that are open with other patients. And the other thing we also do as well is if there is space in the conventional run, they may come from our daytime run instead for 4 hours instead of doing a full nocturnal run, and we would do that as well. So we do try to accommodate in that fashion too. And so part of that with the setup that we have is that these patients, because they're still dialyzing in the inpatient area, we have some flexibility with our AKI spots or acute kidney injury spots, where patients, perhaps there are some patients that are on dialysis and they were discharged from hospital, they're new to dialysis, but they may be recovering. We have actually spots, some flex space there where these patients can come into those spots and dialyze during the day instead.
Excellent. That's really encouraging. I think that it's something that needs to be more available. We don't talk about it on in-center. They don't suggest, you know, if you'd like to trade for, let me know. I do see a potential for patient-led that has not been acknowledged as yet, because I think it's something that we can do quite easily. And it does make a big difference. If I know that I can swap so I can go to something, I think that's really, really important, because otherwise your life is forever saying, well, I'd really like to, but I have to dialyze tonight, or I have to dialyze at 3, or whatever it might be. And that's where a lot of your disappointment with quality of life comes from, that I am so controlled. Yeah. They say, don't let dialysis control you. And yet it does. If I can't change my run because it's not supported and not encouraged and not even mentioned, of course, my quality of life isn't going to be as good, because I'm at the mercy of my dialysis run, not me choosing. Or at least, I mean, not constantly, but you know what I mean? The idea is that you want to go to that concert, or you don't want to come in at 2 a.m, you want to dialyze the next night or whatever. So thank you for that.
Jeff, maybe we'll have one more question. There's a lot of thanks in the chat, but the question from Joanne was about costing data. Do you have any costing data you can provide, either now or after?
Yeah, we haven't. So this is why our nurse manager is part of the unit manager is part of the monthly rounds as well, because what we're trying to navigate is what the demands of the program with what the funding is in terms of what's required. So I don't have specific numbers off the top of my head, but we do, as part of when the program. So when it was set up 10 years ago, part of, in terms of allowing for a program like this to be set up, was really discussing, well, we're going to have less nursing monitoring, and because of that, and there's no nursing assistant monitoring, that perhaps this may allow us to offer this modality for some patients. And so that was actually part of how the program was born. I think now it's becoming more of a discussion around some of the realities for certain dialysis programs, where the demands are increasing as well. And this is, I think, an exceptional modality for patients, that if it really works for them. So when we look at even our dialysis spots in AKC South, we haven't really grown many spots in the last decade, I would say. So it's still the same physical space. And so I do reckon, I think what comes more of it is really maybe some of the realities of where the healthcare system is at, and also what our demands are with our ESRD, growing ESRD population.
Thanks, Jeff. And we're just at the top of your hour. So thanks everyone for your participation. And if you have any topics for other sessions, please feel free to let Selena or myself know. And we will send a recording of the session to the network. And I hope everyone has a great day and a great summer. Thanks, everybody.